and then not the question section afterwards. So ARDS. This is a familiar X-ray for many of us. I won't spend too much time on the background because I really want to focus on the ventilation components of it and then see what people think about my hot takes. ARDS is a syndrome, so it's not a specific disease, but it's a syndrome characterized by life-threatening hypoxemia with inflammatory, so non-cardiogenic pulmonary edema. And it's diagnosed using the Berlin criteria, which would be an X-ray like this, so bilateral airspace disease, profound hypoxemia with a PF ratio less than 300 on at least 5 of PEEP. And in some capacity, we've ruled out cardiogenic pulmonary edema, so heart failure. Now, really what goes on in ARDS, you can see from this X-ray, is nothing good. It depends on what the etiology is, but what we really want to think about from our ventilator strategy and from the ICU is how do we prevent this picture from getting worse? And there are 4 main types of trauma that we organize our ventilatory strategy around in ARDS. So we have barotrauma, which is high pressure damage. We have volute trauma, which would be obviously increased stretch of the alveoli and loss of elasticity. We have atelecta trauma, which is probably one of the more emerging important features of ARDS. And if you think about the normal lung at the bottom versus the more normal lung at the top of this right side, the interface there that's being ripped apart every single time when we put in a breath is going to generate a lot of inflammation and worsen that ARDS into involving the normal lung. And then the last one is biotrauma, which Dr. Slezrev may talk to, but really involves the sort of molecular cytokine inflammatory profiles that happen from ARDS. So this looks crappy. So what do we do about this? How do we ventilate it? And I thought I'd sort of walk through a top 10 list. This was from David Letterman for any of the students out here. And I'll walk through some of the top 10 considerations when we're ventilating patients. So first off, I want to start with low tidal volume ventilation. And this is also in case people stop paying attention, because this is really one of the probably the 2 most important things that have stood the test of time in ARDS research. So what do I mean by low tidal volume ventilation? Now, ARDS-NET, we've seen the ventilation power plans before, but ARDS-NET was a group of hospitals in the West Coast of the United States. And in 2000, they published this paper, which looked at what tidal volume would we want to consider in patients with ARDS. They had 2 groups here. One was a conventional group, which started off at 12 mils per kilo of tidal volume, and then they decreased that down to try and establish a plateau pressure less than 50, compared to a low tidal volume group with a 6 mils per kilo tidal volume titrated to a plateau pressure of less than 30. So they would start at 6, and then they would decrease until the plateau pressure was less than 30 with a minimum tidal volume of 4 mils per kilo. Now, 2 important caveats to this. What weight are we talking about? And then what is the impact, if you can imagine a very poorly compliant lung, what is the impact of having 4 to 6 mils per kilo of tidal volume? So they use these formulas, which I think everybody likes math. So predicted body weight is what they used in this trial. Obviously, patients who have increased adipose or who have increased body size don't have an increase in their lungs as well. And so what they calculated was your predicted body weight. And here you can see for males, it's 50, and for females, it's 45, and then plus the same factors here, which was 0.91 times the height minus 152.4. So that would be what you'd multiply the 6 or the 12 by. And then, as I mentioned, the impact of having low tidal volumes is expected to have high carbon dioxides and low pH. And what they did in terms of management for these groups was if their pH was less than 7.25, they would add a bicarbonate infusion and increase the respiratory rate. And then if it was less than 7.15, despite a rest rate of 30, 33, and bicarbonate, then they were allowed to increase the tidal volume above those barriers. So what did they find? And this is probably, again, one of the most seminal results that we have in ARDS, so I'll sort of walk through it. They found that effectively low tidal volumes were better. That's probably not a mystery at this point. On the horizontal x-axis is days after the study started, and then on the y-axis or the vertical is the proportion of patients. So these 2 top lines are the survival. So in the black solid line, we have the survival of patients who had low tidal volumes compared to that of traditional or conventional 12 mils per kilo in this dotted line on the bottom. So the significant improvement in survival. And then on the bottom is discharged to home from hospital. And you can see on the bottom and the large hash lines is traditional, and then on the top is low tidal volumes. So low tidal volumes had improved survival and improved discharge home from hospital. So this was really a very important paper in ARDS, and it's not really been challenged since then. Now, there's some argument that this paper really showed that that 12 centimeters of water per kilo is injurious, and that a plateau pressure of 45 to 50, which is what they would have had, is crazy. So maybe it's actually 8 mils per kilo or 7, but it's never really been decisively shown that there's an improvement. So we sort of aim for 4 to 6. So with that in mind, my first sort of takeaway from this, I think low tidal volumes, we all would probably agree is important, but what's difficult to kind of get along at the same time, and where I think one area we could be better, is to just basically start ignoring the PaCO2. We know in patients with with low compliance, they're going to have elevated CO2. We have this sort of concept in ARDS called permissive hypercapnia. We just have to allow it to go up to any number. And in fact, if we see somebody with low compliance who has a normal CO2, it's probably more of a concern than the other way around. And then we really have to just start getting comfortable with low pHs. In our sepsis patients, in our trauma population, a pH of 7.15, we're doing stuff. We're adjusting the dials, but we really have to start getting comfortable with lower pHs, because it really just reflects how sick their lungs are. And we don't want to correct it from a ventilator perspective. So the second variable I wanted to talk about was PEEP. Many of you will recognize Little Bo Peep from Toy Story, well, all of them, but Toy Story 4. I cried when I watched this. It was very emotional. But what is the optimal PEEP? PEEP is one of the 2 holy grails of critical care medicine, with the other being how much fluid or Lasix does this person need. And it's really difficult to tell, and everyone has their own take. But why is it so hard to determine a single PEEP for these patients? Well, this is a CT showing an axial, sagittal, and frontal or coronal view of someone with ARDS. And if you just look at the axial stretch, we're at the feet looking up. This is the right side, this is the left side. Try and tell me what the optimal PEEP would be for this area of lung, as well as this area, this, which is air, sort of causing a pneumomediastinum. And then this is almost normal, and this looks almost fibrotic. The idea of finding the specific PEEP for this patient is going to be very elusive. So what we really have to think about is this is a dynamic process. These lungs change every day. So how can we meet that? Now, there are a number of ways to do it. And the standard that was established in the LUBS and alveoli trial, and I think is still in our RT books, is the 2 types of PEEP tables. A number of international guidelines would recommend high PEEP for moderate to severe ARDS. So if the PF's less than 200, a high PEEP table. These tables, though, I guess you can see are probably limited by the fact that they don't take into account that patient variability or change. It really just means that if you have a higher FiO2, as you go up on the FiO2, you should increase the PEEP, but it kind of ignores the patient and their specific characteristics. So what are the other tools we have at our disposal? Well, we have the esophageal balloons and transpulmonary pressure here. This is a screenshot from our Hamilton ventilators. And you can see that when we insert the esophageal balloon, we get an esophageal pressure. And many of you have probably done this, where you watch for end expiration and try and target a slightly positive transpulmonary pressure. And that tells you that you might not have the right PEEP for every alveolus, but you're ensuring that at the end of expiration, the lungs are not being pushed and compressed by the pleura, that they're open, the airway pressure is higher than the pleural. We have the PV tool. This is also on our Hamilton ventilators, and this is kind of nice because you don't really have to do anything like insert a balloon. And this has the inspiratory limb. As we slowly increase the pressure, we can do a recruitment maneuver, or we can go back down slowly, and then it generates a graph that looks like this sometimes, but often looks a little bit more challenging to interpret. And we can use this to set the PEEP as well. Now, it's not as clear what number to use here. There's certainly evidence that when you see this lower inflection point at the bottom, the PEEP should definitely be above there, because beyond this and this area is really almost entirely atelectatic. The 2 points that are being considered are right here. So if you scroll the cursors down, you can find the place where the difference between the inspiratory and the expiratory limbs is the greatest. So this represents volume. And what this would suggest is that in this area, small changes in pressure result in large differences in volume. So you're not requiring as much pressure to get those small tidal volumes. The other argument, though, which is more interesting, I think, but potentially more dangerous, is to go and set the PEEP at the upper inflection point. So you can see here on the expiratory limb, what this physiologically means is once you start to come down, once this train starts going down the hill, you are starting to de-recruit. So what some folks advocate is setting it right about the upper inflection point where you know you have maximal recruitment, and this will be really high. So you can see here it's 24 centimeters of water, but setting it there and then just ventilating small tidal volumes from there and maintaining recruitment. We can also use the compliance that's generated by the ventilator. So this is again a screenshot. The ventilator through its for its mathematical formulas that are proprietary through Hamilton generates a compliance every second. And you can sit there every day, a couple times a day, adjust the PEEP to try and target your optimal compliance. And then of course, because this is a Western PowerPoint, I have to mention ultrasound. Dr. Arnfield has published a great paper looking at using transesophageal lung ultrasound. So we put in the TEE probe and then look at the lungs as opposed to the heart specifically as a way to tell if there's atelectasis, see what happens in real time when you recruit, see what happens at a different PEEP. So you can sort of be guided that way. So how do we decide which of these to use? Now, this is certainly a discussion. I'm curious what people think. What I would suggest, though, is that in today's day and age with our technology, with the intelligence and the skill set of our respiratory therapists, that the tables are really something that we should get away from. We can keep them in mind or maybe as a starting spot, but it's really not patient specific. And I think we can do better. I would propose, because it's the easiest, that at the bare minimum, every day or every shift, we are titrating the PEEP up and down to try and find the optimal compliance. I would expect this to change in the sort of set it and forget it, or just basing it purely off the FiO2, I think is a bit regressive. And then in cases where there's high oxygen requirements, I just said over 0.7, but again, this is not based on anything. We could consider transpulmonary pressure or PV tools to try and guide us. That'd be sort of how I would conceptualize PEEP titration. I think we need to evolve as a group above and beyond the PEEP FiO2 tables. The third thing I want to talk about is driving pressure. So the third variable here, and this is a pressure time curve for a volume control breath, which many of you have seen, so I'll rip through it, but we have an increase in pressure as we deliver the volume up to some peak. The air that goes in this phase has to overcome the resistance of the tube and the bronchi. We can then hold the inspiratory limb and close the expiratory valve so the pressure will decrease. And this represents the resistive component of the lung, down to a plateau pressure, which really reflects what the lung is seeing. So this is the pressure that's being transmitted to the alveoli. And then we can release it again in exhalation. We go down to our PEEP. Now, the difference between the plateau pressure and the PEEP is, again, what's really being affected on the alveoli. So this is what we can think of as being responsible for that atelecta trauma and probably some of the barotrauma as well. So why am I going on and on about driving pressure? Because this is somewhat of a newer concept. Now, so the reason is because it seems to be important, obviously. This trial looked at every ARDS, every major ARDS trial, and it took every ventilatory parameter that exists, plateau, peak, tidal volume, et cetera, and looked at the implication of changes on mortality. And what it found was that driving pressure mattered and had the greatest impact or correlation on mortality. So this is a bit of a confusing graph, and I'll explain it. On the bottom, or the x-axis, is the driving pressure, delta P. So that's that P plateau minus PEEP. And on the y-axis, or vertical, is the relative risk of death in the hospital. And what you can see here is that a value of 1 means there's no difference either way. As we go up to higher numbers, more of these patients died. And as we go towards 0, less patients died. The number at which this crosses 1 is 15. So patients who had a delta P less than 15 in all comers, this was tens of thousands of ARDS patients, had an improved survival compared to those who had driving pressures that were higher. Now, the argument here is that patients who are healthier and have better lungs would have lower driving pressures, which is true. You'd be able to get those tidal volumes with lower driving pressures. However, this bears consideration. If we can get by in a patient with lower driving pressures and we can get that delta P under 15, that's going to be hugely impactful. And this had more of an impact than the other variables I'm going to talk about today. So I think it bears thinking. There hasn't been a randomized trial about delta P, but I think it's important. related to driving pressure or involved in the calculation is plateau. And I sort of already talked about how we accomplish our plateau pressure. We think of this as the pressure that the alveoli are actually seeing, and it's done with an inspiratory breath hold. In the ARDS-NET trial, they looked at it titrating to a plateau pressure of less than 30. And that's really stuck by, that's in all the international guidelines in addition to low tidal volume. So we really want to be trying to adjust our plateau pressure to be less than 30. Now, another point of discussion, which I don't think we know yet, is how can we accomplish that? So if we have PEEP, which we're using our PV tool, our transpulmonary pressure, it's telling us to set the PEEP at 22. It's gonna be pretty hard to get even 4 mils per kilo in with just a driving pressure of 8. So I'd be curious people's thoughts. I think that what we've seen and what our understanding of the trauma of ARDS, that PEEP and recruitment, optimal recruitment is important. So I wouldn't sacrifice PEEP. I would favor maintaining the driving pressure less than 15 and accepting a higher plateau pressure in that situation. So I'd be curious what other people think. We have a chat. I agree. Thanks, Moran. Okay. Now mode. Hopefully this is the most upsetting to the RTs on the line, because I think we can do better in terms of mode. Here we have 3 different pressure, volume, and time curves. So on the left, we have a volume controlled breath with a square wave flow curve. In the middle, we have pressure control. And on the right, we have APRV. I'll sort of talk about which modes we think about and what I think we should be doing. So why would we use one mode versus the other? So volume control, the benefit to volume control is that we guarantee the tidal volume. So we set, if we know that 4 to 6 mils per kilo ends up being 350 to 400 cc's of tidal volume, we just set it and it's going to be correct with very few exceptions. So we can set the volume control. We know we're getting that tidal volume, and tidal volume, as I mentioned, is one of the 2 things that's been shown to decrease mortality in ARDS. The problem with volume control is obviously you can't control the pressure. So pressure control is going to potentially minimize the barotrauma. And then in cases where there's asynchrony or patients with restrictive lung disease, there might be a benefit to the flow variability in pressure control. Now, how about ARDS? I feel appropriately so, like this is many of our RT friends' favorite mode to talk about. And I'll sort of go through there's one trial that looked at this. So this was a trial from China. It was obviously published in 2017. And it was an open label trial. What was nice was the RTs controlled the anesthesia because we're doing APRV, and that was sort of respiratory therapy type of situation. So they looked at patients who had ARDS, not in refractory shock, intubated for a short period of time. They only had 138 patients. It was a single center trial with a mix of etiologies of ARDS. And they randomized them to APRV, which was, again, RT controlled. Patients were breathing spontaneously or just traditional ARDS-NET. And their primary outcome, which was ventilator-free days, was statistically significantly different. So 19 days as opposed to 2. Their secondary outcomes, there was more successful extubation, less tracheostomy, and their ICU mortality was decreased, but not statistically significant. This was really interesting and sort of provocative, but this has not been reproduced in any other North American or Western European sort of traditional multi-center RCT, and it's based on sort of physiologic extrapolation. So that's the rationale for APRV. So I think the justification for sort of switching what I believe is our most common mode of pressure control to volume control comes from the following. This is a chart showing all of the trials in ARDS over the last 21 years. And we'll just sort of go through what they used and then why I think that's important. So ARDS-NET initially in 2000 used volume control. The alveoli trial, which established those high and low PEEP studies in 2004, used volume control. The FACT trial, which was conservative, so low, it's conservative versus liberal fluid management, so high versus low CVP, used volume control. The LOVES trial, which was done out of Hamilton, used volume control, but they also had pressure control for the recruitment maneuver arm. The Accurasis trial looked at neuromuscular blockade and was the reason we started using cisatracurium all the time. That was volume control. Prosiva was pronine, and that was volume control. ART, which was the open lung strategy was similar and basically copied the Love's trial, same ventilation profile. EPVent, which was the transpulmonary pressure trial, looked at they could use either volume control or pressure control. And then Rose and Dex ARDS, which came out in the last 2 years, they don't specify, but it sounds from their results like they used volume control. So that kind of gives us a sense that virtually every major trial that's come out in ARDS that's a landmark has used volume control for the reasons I think I outlined initially, that it guarantees us low tidal volumes. Cochrane, which is the biggest reviewer, meta-analyzer of trials in 2015, said that there's insufficient evidence because these two modalities had never been studied against one another. And then my highest quality of evidence in ARDS is Dr. Champion, whose notes and personal take is that there's no evidence for one mode being better than the other. So with that said, I still think that there's enough evidence that we would benefit from being in volume control, and I'll outline how this is actually played out in real life. So I think in terms of mode, our default should be assist control, volume control, at least for the first couple of days until we establish good lung protective ventilation. If patients have dysynchrony and we think that the flow might be helpful, we can add into pressure control. Refractory patients, I think APRV is a good consideration, and there's not a lot of evidence for that right off the bat. And then I really don't think we should be using adaptive support ventilation off the bat in patients with severe ARDS, because I don't think it's designed for those patients. So that's the mode. PaO2 and PF ratio. So how do we adjust our ventilator according to these variables? This is a diagram showing the delivery of oxygen that goes to every tissue per minute. You can see here, we've got delivery of oxygen is cardiac output times 1.39 times the hemoglobin times the SAT plus 0.003 times the PaO2. And why I think this is significant is because it really shows you in a graphic format how unimportant PaO2 is to the oxygen content of blood and to the oxygen delivery of blood. Changes in the PaO2 will be about 100 to 1,000 times less important to the oxygen delivery of the blood than changes to the SAT. So where I commonly see this sort of applied is patients who have SATs of 91, 92%, but a PaO2 of 55, and this results in them having an increase in their FiO2. And I think that has two negative side effects. One, it makes the patient look sicker, and it also can decrease their PF ratio, which I'll explain in the next slide. So I think we really need to start ignoring PaO2. It does not contribute in a significant component to our oxygen content, and it doesn't particularly matter unless you have a hemoglobin that's in the 30s. So why was I talking about PF ratio? This has become, because of the Prosiva trial and the proning, this has become the most important variable that we look at. So PF ratio is obviously the PaO2 to the FiO2. And I think that most of us believe that the relationship exists along this line. So this is what happens, what we think happens. If you go from an FiO2 of 0.4 up to an FiO2 of 0.8, you're going to double or more the PaO2. And that is true in patients with normal lungs. So the relationship is linear in patients with normal lungs. But what is important to consider is that our patients don't have normal lungs. So these percentages are what's called shunt fraction. That's the percentage of blood that's going through lung that's not ventilated. And if you look at the bottom here, this is a 50% shunt. If you have a patient on 0.4, so 40% FiO2, and you increase their FiO2 to 0.8, you're going to have effectively no change in their PaO2, but their PF ratio will decrease by 50%. So you can, depending on their shunt fraction, which we can't measure or we don't measure, you can dramatically impact their PF ratio. So because it's so important for determining when we change therapies or when we prone patients, I think it's worthwhile. My suggestion or my thought is that the second point, we should start doing PF ratios at whatever the lowest FiO2 required is to get their SATs above 88, because that's really what we're targeting. And we should try and use FiO2 judiciously. And second of all, I think we should just straight up start ignoring PaO2. It does not contribute to your oxygen content, and it doesn't matter. What about recruitment? We talk about recruitment not infrequently. This is a trial. This was the ARDS trial I mentioned from 2017. And they looked at two groups. This is survival or mortality. And they looked at a low PEEP group, which was just ARDSnet with the PEEP tables, and then lung recruitment and titrated PEEP. And these folks had QID recruitment. And they looked at their survival. So you can see here that the patients in the low PEEP group had a survival that was worse, or that was better than the patients who had the recruitment. And that's evidenced by the hazard ratio here, which is 1.2 and did not cross 1. So there was a mortality increase from regular recruitment. And this was likely a couple of cardiac arrests that happened during recruitment maneuvers. So I would suggest that recruitment should be saved really for refractory cases, patients we have evidence for, but not everyone with ARDS. Proning, I'll talk about number 8. So what is the utility? How do we think about proning? Now, all the proning literature comes from this ProSiva trial, which was published a few years ago. What they did was looked at patients who had been ventilated for less than 36 hours. They had to have been stabilized and sort of optimally medically managed for at least a 12-hour period. And in patients whose PF ratio was less than 150 within 1.5 days of admission, they got prone for at least 16 hours per day. And then they were put back in the supine position for a remaining period. Now, most patients were prone for between 4 and 6 days with this. And what they found was a really impressive survival benefit. So again, this is days on the horizontal and probability of survival on the vertical axis here. And the prone group here had a massive decrease in mortality compared to the supine group. So this is really how we used, this trial, and this is how we use PF ratios in order to determine whether or not patients would benefit from proning. I think that there is some limitation to this. Understand that if we consider this in patients who are past 36 hours, or patients who have severe hypotension or home oxygen, home NIV, that wasn't studied in those groups. So proning seems to be a very effective strategy. I guess the other thing to include here is they started to reduce the proning when their PF ratio was above 200, or their FiO2 decreased by 20%. What about paralysis? So there have been 2 trials that came out in paralysis. The first was the Accurasis trial, which showed cisatracurium curium decreased mortality. And the second one, this is Belle looking at her ROSE. So there was the ROSE trial from the Tidal network. And just one second. One number. So the ROSE trial was a repeating of the Accurasis trial. So it looked at regular neuromuscular blockade in patients with PF ratios less than 150, who were treated with sort of conventional SBTs, SATs, and light sedation. They found that there was no difference. So in patients who have a PF ratio less than 150, there was no difference in survival to hospital discharge or discharge to home. So for this reason, we really should be restricting neuromuscular blockade to patients who have asynchrony or dysynchrony despite deep sedation and trying a variety of different modes. It does not need to be done for everyone who's prone, and it does not need to be done for everybody who is severe. And what about ECMO? I think John Lana might be on the line, so maybe he can jump in afterwards, but there have been a few trials in ECMO. This was the first one, the Caesar trial, which looks quite lovely right now. I think Barney's is open. And they found that on the right, the patient survival of patients who were transferred to an ECMO center was significantly improved. So this is survival in the red, this is the ECMO group, and then this is the blue conventional management. Now, the caveat here is that only 64% of patients transferred to the ECMO center received ECMO. So this was followed up with the Eolia trial. And it basically found that there was no difference. So this was the ECMO group here had 100% of their patients or thereabouts got ECMO, and the control group was treated according to standard medical therapy, all the other things I mentioned, and the p-value greater than 0.05 suggested that they're, again, in patients with severe ARDS or very severe PF ratios less than 80 or less than 60 for a few hours, did not benefit routinely from ECMO. Now, if we do have patients on ECMO, what are the recommendations? These are the local recommendations, which you can find on the intranet. And I'd be curious, again, what people think how well we accomplish this. This largely echoes or follows the international ELSO guidelines. So they suggest here pressure control ventilation, which is obviously different from what I've said. A pressure control of 10, a plateau pressure here of less than 25. You can see at tidal volumes, they're recommending a maximum of 4 mils per kilo ideal body weight down to 0 with an inspiratory time less than 1 second. The PEEPs ranging from 10 to 15. So this would be significantly less than we would think about in somebody who's not on ECMO. And that's largely because of the effect of intrathoracic pressure on the lungs, as well as the access cannula and the fact that we're not using the lungs, a very low respiratory rate, and then trying to target a SAT of about 85%. And this is even higher than ELSA would recommend. So I don't really think when we've had our ECMO patients that we do an excellent job of accomplishing this type of ventilation. So if you're like I forget which witch this is on the left, there's lots of Disney today. If you're like this witch on the left, you think that, well, that's just what you're telling us, we already do a great job. I'm going to try and explain why I don't think we do the greatest job. So this was an audit from MSICU a few years ago, and I would posit that it's similar to the CCTC culture. This is a pie graph showing the distribution of tidal volumes. So you have here less than 6, 6 to 8, 8 to 10, and then above 10. 14% of patients who have ARDS based on that Berlin criteria I discussed at the beginning, 14% are getting low tidal volume ventilation, with over 78% of them getting somewhere between 6 and 10. Now, is there evidence that 6 to 10 is not better? No, but there is evidence of less than the 6 being better. So I think that this is certainly an area where I could see us improving, and that's tidal volume. In terms of how well we're recognizing it and the physicians are doing on this part, you can see here that we're documenting it. I think the purple numbers are more interesting. So 77% of the time we're documenting in the chart, 56% of the time it's making it into the RT chart, 48% of the time it's ordered, and 33% of the time it's initiated. So this was presented as a quality study from LHSC a few years ago, and I don't really know if we've done much in terms of improving it. And then in terms of our ventilation and fluid balance, you can see here 16% of the time we meet our target tidal volume, 55% our target PEEP, and 50% we have a positive fluid balance in 24 hours. So I think that there's a lot of room for improvement here. So in summary, I really think that this is an area where I'd love to, we can love to leverage the help and the insight and the experience and the knowledge of the RTs and the nurses that we work with to sort of take this data and really use it as an opportunity to advocate for patients and to push it back on the physicians and say, we've done everything, we've tried this, I can't get their tidal volumes down, we're doing all these things, I need to have this done, or we need to think about this. I think it's really an area where we can have our sort of all of us coming together to try and move us closer to this 2021 version of ARDS ventilation. In terms of what's actually stood the test of time and been studied in high quality data, it's these top two. We got to always circle back to this. Are we doing lung protective ventilation with low tidal volumes, with plateau pressures less than 30, with driving pressures less than 15, and thinking about their PEEP? And then are we proning patients who, despite this, have a PF ratio less than 150, and are we doing it regularly? I think we need to basically abandon our love of PaO2 and PaCO2. They don't manifestly change our management, and it just becomes a distraction. It's hard to ignore red numbers. I think we have to keep the rescue maneuvers in our back pocket, like neuromuscular blockade, recruitment, inhaled nitric oxide, and ECMO. But these are really not things we should be instituting as a regular routine basis for our patients. And I just wanted to finish with a plug and sort of a description of our COVID-19 invasive ventilation lung protective strategy, which I think echoes a lot of the stuff that I was just going through. So this top bar, this is available on the intranet and was sort of used to guide us. This was based on discussions among both sites. The top, we've got recognizing patients. This is the initial ventilator mode. So you see we're recommending and thinking of starting in volume control, 6 mils per kilo, PEEP of 10, FiO2 of 1, record their variables, their plateau and their compliance, and then try to get their FiO2 the lowest possible. You can see here if their plateau is less than 30, reducing the tidal volume by 1 mil per kilo, and then recording an ABG and sort of titrating. So we can do things to try and get to these targets. Plateau less than 30, good compliance, driving pressure low, all the things we talked about. And this is on the intranet. So that is it. I'm thankful that there were so many people here. I'll stop recording and then see if anybody has any thoughts or questions.